Thank you, Perry, and thank you for the opportunity to speak today. So we can start with the slides. All right, so my topic was a difficult topic, but how does the cornea respond to laser-induced limbal elastic incisions, and specifically corneal remodeling? And so I'll try to answer that question in this talk. And what I wanted to start with is, well, that, but also, why is any of this important to us? And really, why does femtosecond laser have a role in cataract surgery? And I started with, are our current refractive results good enough? And these are our refractive results, and this is the percentage of patients that come out within plus or minus 1 diopter of what their target is. And we had 74%. And the causes for this can be capsulorhexis, it can be lens position, IOL calculations, and residual astigmatism. Now what happens when we fine-tune that and say, forget a diopter, what happens within plus or minus half a diopter? Well, we come up with this. So within half a diopter, 45% of patients hit that target, which means that 55% of patients are not delivered within plus or minus a half a diopter after surgery. Well, how important is corneal astigmatism to all of this? And I would argue that it's fairly important. Almost 90% of patients have some degree of corneal astigmatism before cataract surgery. We have several ways to address this. We can do it in the operating room with a manual LRI or arcuate incision. We can do it with a toric intraocular lens. And we can do it with a femtosecond laser. And each one of these approaches has pros and cons. So when we look at each of these, we have several considerations. The toric lens, there are gradations, the power that we insert. Additionally, we're addressing a corneal problem in the lenticular plane. And we look at blade, LRI, or AKs. We have skip lesions. We have the ability, we have the potential to perforate through the cornea. And we have lack of precision when we create these incisions. And then the femto laser, which gives us the ability of no skip lesions and increased precision. So let's look at what we do now, blade, AK, or LRI. Potential problems. And there's a slew of them. We have a possibility for infection, weakening of the globe, perforation, decreased sensation, regular astigmatism, misalignment or axis shift, wound gate, operating the wrong axis, and precision of the effect. And so we take all of those potential problems and say, okay, what does the femto laser do for us? On a high-level approach, you can say, well, it will make the incision more precise, and the depth will be there consistently throughout the entire incision. But what about the other issues? How does the femtosecond change our current profile? And I would argue that these things can be addressed just by software treatment planning. That by planning and putting all the parameters into a computer, it can measure the corneal thickness, we decrease our risk of perforation, operating on the wrong axis, or having these incisions perfectly aligned on axis. But that leaves us with these topics. How does the laser affect each of these different things? So to answer this question, I had to dig back. And we have to remember one concept. What were each of you doing in 1967? And do you remember, buddy, do you remember 1967? So
I wasn't born yet.
This is 1967. And if you remember this, I would bet you guys did not download this on the Apple iTunes store, but you bought a vinyl record, right? Same way if I went into one of your houses, and I wasn't alive in 67, so I can't say this, but likely if I wanted to adjust the temperature in your house, you would have had something like this. Whereas now, you have this, and you can adjust temperature to a decimal point based on this. So why is that important, and am I crazy for showing this? Well, I think that there's this idea of digital versus analog, right? The same way today, the engineers in this first session, they can deliver something that's very precise, but the reality is you're dealing with a tissue, and the tissue response to this, regardless of how precise it is still variable. And so, as clinicians, what can we do to say we want to try to regulate the tissue response so that it is the most consistent broad spectrum across different patients who present to the clinic? So I tried to answer this, and I'll proceed. And basically, when we design these incisions for arcuate incisions, we can do this, and this is just showing, using the current intralaser laser. Here are some of the things that we can do to try to improve our reliability of tissue response. So sub-Bowman's incision, well, it may affect wound healing. Why? It throws out our current idea of epithelial damage and that cascade of wound healing. And on several levels. One, that cascade is different, but two, there's no more surface irregularity, epithelial hyperplasia at these breaks where the incision is formed. And you could argue that maybe the use of femtolaser subbomens will also sort of result in less disorganized collagen fibrils, which we started off today's session talking about in the morning. But what about decreased risk of infection? There's no longer an epithelial break. Or impact on corneal sensitivity and neuroregeneration. We've seen talks at ASCRS now in terms of breaking the epithelium and the increased risk of dry eye, depending on how large that incision is. But also, we've seen this in literature, that the depth of these incisions and the width of these incisions, or angle, will actually impact regeneration of nerves and sensation of the cornea. Depth in the stroma. Now, this is the idea that we might be able to pair incisions, and one may be anterior, and one may be posterior, and this may actually result in steepening in one axis and flattening in another axis, depending on what we need for the patient. And then we come to this idea of what about the side cut angle? So when we look at our LRI current nomograms, we account for age, we account for PK versus cataract surgery, natural astigmatism. But what about the ability to change the angle? And so this is starting to come out, and Zaldivar and Huang and Buddy Culbertson all have talked about this. The reality is, if we change these angle positions, do we have an impact? Do we have the ability to avoid wound gape? So if we make an incision on a steep axis that's pointed outward versus inward, do we inhibit wound gape? Do we inhibit the ability of epithelial plugs to form? If you see old AK incisions that are splayed open and it looks almost like sausage links of epithelium that are in these incisions, do we take the ability of that out by doing this? And then do we also impact collagen remodeling when we have a straight incision versus an angled incision? So I think that really where this turns to is now optimizing our nomograms and optimizing the tissue response to a laser, which we have very good control over. This is one case of a subbomens arcuate incision of a patient who was treated at Bascom Palmer. This is a 61-year-old man who had a tetanus multifocal, unhappy with vision, uncorrected vision was 20/50, best corrected 20/20. And you'll notice that the manifest refraction did not line up with the topographic amount of cylinder that was present. Okay? So this patient was treated, and we used our current intralays. This is an off-label use again to do this, and we did a subbomens incision, and you can see this is immediately post-operative. Was minutes after surgery, roll the patient's line, took a photograph, and you can see the angled incision that's present here. And then you can see what the anterior segment of OCT shows where the femtolaser did this subbomens incision. So the question is, how long does that last? What happens to this issue a month later? What happens to this issue 3 months later? And is the effect still present? And I can tell you, at week 1, the patient had best corrected vision of 20/20, uncorrected 20/25+3. You can see the topographic amount of astigmatism that's remaining. And you can see that our incision's already changed by week 1, and that opening, the cavitation area, is now closed. So you can see a visible incision that's clear. You can see a linear pattern, an increase in optical density. And I can tell you, at 3 months post-op, this patient still has a stable refraction, and still uncorrected vision of 20 or 25. So I want to thank the team that we have, and I have to particularly thank in front of each of you, Buddy Culbertson, who's been a great mentor to me and has been a fantastic person to work with. So thank you.
We have 2 papers to go.